going to discuss about very interesting cases regarding to rickets, which is a common presentation. And we know most cases of rickets are related to vitamin D deficiency, but there are substantial numbers which are related to resistance to vitamin D. And these cases are associated with abnormalities in either the renal handling of the phosphorus, the acid, or the calcium, or there is some problem in terms of vitamin D activation or action. Today, we're going to discuss about 4 very interesting, diverse types of cases, which will focus upon different etiologies of refractory. Boy who presented with rickets and was given a case of vitamin D dose was given. The parents were really concerned about bone pain and a high level of alkaline phosphatase, which was found on follow-up. And calcium levels were normal, and the patient was labeled quote unquote as refractory rickets. Now, as well, we'll discuss about that. We need to understand that once you treat, there are different changes which may happen, which can cause bone pain, and the ALP is a marker of bone formation, and the levels may go up. So this is not really a case of refractory rickets, because once you label refractory rickets, you have to do many complicated investigations like blood gas, PTH, vitamin D, calcitriol, which is not going to help out and will cause more confusion or problem. So this was clearly a simple case in which if we had looked for the line of healing, it was present. So this was a classical case in which we were messing up with a simple case, making it more complicated in that regard. So this was a normal response. On the contrary, we have this 14-year-old boy who presented with rickets with very early onset from around 3 to 4 years. And we can see significant lower limb abnormalities, has received huge amounts of vitamin D. There was no response as far as the radiological picture was concerned. There was no line of healing. And despite that, vitamin D was continuously given, which had unfortunately resulted in nephrocalcinosis. Now, this is a prototype case of refractory rickets in which it was found to have hypophosphatemic rickets. So we have got the 2 extreme scenarios, one where we are unnecessarily messing up a case, and here what we are messing up a case. So this is the scenario which is there from that regards. So rickets can either be missed, and this can have significant consequences. It is a common disorder. 90-95% are nutritional, but we need to identify individuals who are unlikely to respond to vitamin D because they require comprehensive evaluation and assessment from that regards. All of you can go and have a look at our website, Learning.Grow Society, which is a learning portal providing courses about pediatric endocrinology, including fellowship and diploma programs. We do run regular activities in the form of journal clubs, postgraduate lecture series, and grand rounds like this, which provide insights using case-based approaches. We have got publications in pediatric endocrinology, which are available both online as well as in a hard copy. Application also helps in terms of day-to-day management. So today, our agenda would be to focus a bit about rickets to begin with. Then we'll talk about hypophosphatemic rickets, a very interesting case by Dr. Vibha. Then Dr. Yeting will be talking about the case of VDDR. Dr. Musa will also talk about a similar case which we encountered. So just to contrast the 2 approaches there. Then we have a case of proximal RTA by Dr. Manoj and distal RTA via Dr. Dhwani. And this will really complete the entire picture of the 4 major causes of refractory rickets. Now, when we talk about rickets, we are talking about 2 things, calcium and phosphorus. Now, both of them are important for bone formation, but the most important is actually phosphorus. And it's the phosphorus deficiency which is actually responsible for rickets, because phosphorus causes a chondrocyte apoptosis. If the phosphorus levels are low, you will not have apoptosis, and therefore the growth plate will grow more and you will develop rickets. So rickets is essentially a problem of calcium and phosphorus. And we know that the major regulator of serum calcium is actually vitamin D axis. So vitamin D, which is produced either under the exposure of sun or 5% from the plant sources, is then activated by the liver to 25-hydroxyvitamin D, which is further activated via 1-alpha hydroxylase into calcitriol. And this calcitriol then causes the effect which happens in terms of increasing absorption of calcium from 25% to 40%. And if you are deficient in either vitamin D, in 25-hydroxylase, 1,25-dihydroxylase, or if you have a problem in vitamin D receptor, you will develop a refractory rickets. There is also an inactivating pathway of 24-hydroxylase, which inactivates this to inactive form, and which basically results in decreased action from that perspective. Phosphorus levels in the body are largely determined by how much is the urine excretion of phosphorus. So major disorders of phosphopenic forms are associated with low level of serum phosphorus and a high level of urinary phosphorus, which is reflected via a low level of tubular maximum of GFR, which is TMP GFR. Now, phosphopenic rickets needs to be differentiated from the calciopenic rickets, which is basically a calcium and vitamin D problem. But remember, all forms of rickets are ultimately phosphopenic, because if you have calcium deficiency, your parathyroid hormone will go up. And as soon as your parathyroid hormone goes up, you will lose phosphorus in the urine. So everybody with rickets should have a low phosphorus, and that's an important distinguishing point. If your phosphorus is high with rickets, there are only two conditions you are thinking of: renal failure or a pseudo hypoparathyroidism. So phosphorus deficiency is common, but if it is because of secondary hyperparathyroidism, then you will have the calciopenic rickets. While if it's because of a primary tubular pathology, your PTH will not be high, you will basically have a phosphopenic form of rickets. So phosphopenic rickets could be part of a generalized tubular dysfunction like Fanconi syndrome, or a specific problem in which the phosphorus losing substances are more in the body, which is the phosphatonins, typically FGF23, which is acting via the hypophosphatemic rickets. In this condition, you will not only have phosphorus deficiency, but also the increase in calcitriol does not happen. Anybody whose phosphorus goes down should have a high calcitriol. So here the FGF23 not only causes phosphorus excretion, it also causes inhibition of 1-alpha hydroxylase. So these individuals, you need to treat with both calcitriol as well as phosphorus in that regards. There is one exception in which there is a problem of the sodium phosphate pathway, wherein you will have hypophosphatemia with high calcitriol. And this is going to cause you hypercalciuria. So if you have hypophosphatemic rickets, always measure urinary calcium before you start calcitriol, because you may have that NP2 variant which may cause nephrocalcinosis will develop quickly. So this form of rickets typically presents late, predominantly with lower limb abnormalities, and otherwise the child looks normal. He is not sick from that perspective. While the calciopenic rickets can start right from decreased exposure to sunlight, decreased calcium intake, a chronic liver disease with malabsorption, use of anti-epileptic drugs which increase inactivation of vitamin D, abnormalities in the kidney functions like chronic kidney disease, decreased production of calcitriol, which is vitamin D dependent rickets, and you will have an early onset rickets in a sick child who develops tetany and hyperparathyroidism. So if you want to distinguish between calciopenic and phosphopenic rickets, having hypocalcemia, having hyperparathyroidism excludes a primary phosphopenic pathology. This is an important thing to remember. So PTH becomes the second very important investigation when we talk about evaluation of rickets. There is also a third group of disorders, which is because of tubular abnormalities, largely because of metabolic acidosis. Now, these disorders are not really affecting the vitamin D to a great extent. The acidosis itself is causing abnormalities in the bone. So these disorders will present to us with failure to thrive, with polyuria, with nephrocalcinosis, so distal and proximal RTA. Now remember, proximal RTA presents earlier with much lower level of phosphorus. You will have urinary glucose or urinary amino acid uria. The severity of acidosis will be milder in proximal RTA. So you may miss actually these cases. Distal RTA presents a bit later, but the severity of acidosis is much more. You may have hypokalemia. You will develop nephrocalcinosis. And if you don't treat early, you will develop pathological fractures, very, very fragile bone. So later onset, 6 to 10 years of age, significant failure to thrive, hypokalemia, neck flop, fractures, think of a distal RTA. First 2 to 3 years of life, very low phosphorus levels, urinary glucosuria, start thinking of a proximal RTA from that perspective. So now, based upon that perspective, we can classify rickets into deficiency, which is both calcium and vitamin D, in which you can look at the therapeutic response to rickets. Then it may be refractory, which can be calciopenic because of VDDR 1 and 2, renal failure and malabsorption, which is early onset hyperparathyroidism and hypocalcemia. You can have acidosis because of proximal or distal RTA with polyuria, failure to thrive, and if it's distal RTA, you will develop nephrocalcinosis. And finally, you will have the phosphopenic form in which you have hypophosphatemic rickets, Fanconi's disorder or malabsorption associated with late onset lower limb abnormalities with normal calcium in PTH. So if you now remember just two things, phosphorus, calcium, PTH. These three will classify all your forms of rickets and we'll use it for further evaluation. Now the big question is, when you're facing a child with rickets, is it really rickets? If it's rickets, is it refractory rickets or not? And then finally, what is the cause? So rickets, of course, is a radiological diagnosis, but clinical parameters can give you a clue. So you can have a genu valgum, genu varum, and windswept deformity. Now remember, genu varum may actually be a normal phenomena in infants. So if you have a windswept deformity or a genu valgum, that is much more significant. But remember, 1 to 2 years, you can have some form of bony which may happen. And of course, we know about the cupping, fraying, and splaying. All those are characteristic. The next question is it refractory or not? The answer, of course, is that you should give a therapeutic trial of vitamin D and wait for that. So these are the guidelines by the Indian Academy of Pediatrics, which are similar to the consensus statement by the global team. They talk about 60,000 international units fortnightly for 5 doses beyond 12 months or 3,000 international units daily for 12 weeks. So you have to wait for 3 months to get the response, and then you will decide whether it's refractory or not in that regards. Now remember, when you give vitamin D, you will cause increased absorption of calcium and phosphorus. And this calcium and phosphorus will go into the bone to cause deposition and mineralization of the bone. Now, in this scenario, if you are deficient in calcium and you are not giving calcium, you may develop what is known as hungry bone syndrome, or there may be bone pain. So bone pain may be a normal phenomena which may happen. So always give calcium with vitamin D. So this is common. The second thing to remember is that when you are actually giving calcium and phosphorus, the overall turnover of bone will become more. Your osteoblast will act more, your osteoclast will act more, and osteoblast will produce alkaline phosphatase. So alkaline phosphatase levels may rise during the initial phase of treatment. This is basically a marker of a response. It's not a marker of refractory rickets. You have to be cautious about in that regards, and rise in ALP may happen. So the gold standard for response is the line of healing. That is what you need to look at in that regards. So refractory rickets, you need to show that there is rickets, both clinical as well as radiological, and you have given adequate calcium and vitamin D for 12 weeks. There is no line of healing. This is refractory rickets to you. But remember, in certain scenarios, there may be confusion which may cause diagnosis of refractory rickets, particularly, as I said, high levels of alkaline phosphatase, hypocalcemia, and bone pain after treatment, which does not mean that you have rickets. It basically means that this is a normal nutritional rickets which is responding. Wait and watch for more time. Other things which may cause rickets are like skeletal dysplasia, pseudo-hypoparathyroidism, or fluorosis, which may look like rickets. And of course, because they are not rickets, they will not respond to vitamin D, and you may label them as a significant case of a pathophysiological cause. One condition important is hypophosphatasia, and this is characterized via an absolutely low level of alkaline phosphatase. So I've talked about calcium, phosphorus, PTH. The fourth player is alkaline phosphatase. So if your alkaline phosphatase is high, that is a normal response. If ALP is normal, you may be dealing with RTA, which is a low bone turnover. If it's very low, think of hypophosphatasia. So alkaline phosphatase is very important. But many times, first time you are seeing the child, you may think, okay, this is something important. I want to exclude a refractory rickets. So if there is polyuria, fractures, normal nutritional rickets does not cause fractures. So if there is a fracture in a child, significant failure to thrive, you think of refractory rickets. So we've now known that this child has a refractory rickets. a good dose of vitamin D and calcium was given, but still he is not responding. So what's the cause? So from here, we will need to understand what are the causes. So this is from my publication long time ago. And what we see, the four major causes was distal RTA, proximal RTA, VDDR, and hypophosphatemic rickets. And we'll be presenting all four of them in the discussion today. If you go by the Western textbooks, they talk about distal RTA not being a cause of rickets. The reason is if you pick them up at an early stage, they will not develop rickets. But if you delay the diagnosis, like often happens in that regards, you would have a delayed diagnosis and that will cause a significant problem from that perspective. So you need to be cautious about in that perspective to evaluate and assess from that regards. So always take a history of if there is any tetany or any features like that, you can think of a calciopenic rickets. If there is polyuria, it indicates renal tubular acidosis. If there is a primary lower limb abnormality, this is more like a phosphopenic rickets. On examination, if there is anemia, this could be celiac disease or a chronic kidney disease. If there is alopecia, particularly alopecia totalis, this could be a variant of vitamin D dependent rickets type 2, particularly the ligand binding domain causes this. Look for the eyes for the crystals, and this could be an indicator of cystinosis. Hemangiomas, and hemangiomas are important because they may secrete FGF23, and if you remove those tumors, your rickets will improve. That will be an important thing. And of course, if there is mottling of teeth, think of fluorosis as a possibility. Now, if you look at clinical parameter that we have mentioned here, the most important, of course, is calcium. Calcium will, of course, be very low in VDDR. Phosphorus will be low in everybody. ALP will be higher in most, but not that high in distal RTA. So basic parameters will help you out in that regards. And nephrocalcinosis, of course, will give you a direct picture towards the diagnosis of a distal RTA. Important to remember is that amino acid urea, which is a marker of a proximal tubular dysfunction, may also happen in distal RTA because of secondary hyperparathyroidism. So this is the paper that we published there subsequently. So if we now look at the primary causes, I've mentioned those four causes along with renal failure and PHP, so 6 causes. The most important is phosphorus. If your phosphorus is high, it's renal failure or pseudo-hypoparathyroidism. Then calcium, if it is low, it excludes hypophosphatemic rickets. A normal calcium and a normal PTH suggests the possibility of a hypophosphatemic rickets. So generally, everybody who has rickets should have a low phosphorus and a high PTH. If your PTH is normal and phosphorus is low, think of a hypophosphatemic rickets. And of course, urinary calcium, if it's high, it's more like a renal tubular acidosis, and acidosis will also give you a picture. So most important thing is phosphorus, second is PTH, and then of course, ALP and urinary calcium will give you a clue. So back around 17, 18 years ago, we gave an algorithm at that time based upon our results. Results are pretty similar. So this is our current algorithm. So first, of course, is to look for response for vitamin D, maybe wait up to a period of approximately 3 months. If there is response, it's a deficiency rickets. If there is no response, look at phosphorus. If phosphorus is low, you can have RTA, you can have VDDR, and you can have hypophosphatemic rickets. So look for blood gas. If it shows acidosis, that is renal tubular acidosis, you classify using urinary pH, urinary carbon dioxide to blood carbon dioxide difference. You can use this fraction excision of bicarb into proximal or distal RTA. We'll talk about this a bit later. If the blood gas is normal and your calcium and PTH is also normal, this is hypophosphatemic rickets. While if you have hypocalcemia, you have VDDR, which you can classify using calcitriol level. Low level suggests VDDR1 and high level suggests VDDR2. Remember, calcitriol should be done only when needed. If you do calcitriol level in vitamin E deficiency, the level may be low, normal, or even high. So it's not a very, very good marker because it is affected by PTH. It's substrate independence. These are the all problems which happens with calcitriol. Now, on the other hand, if your phosphorus is high, only 2 diagnoses are there. If creatinine is high, this is renal failure. If creatinine is normal, this is pseudo-hypoparathyroidism. So, of course, look at response to vitamin D, look at phosphorus, low phosphorus, look at blood gas. If blood gas is normal, calcium and PTH, If phosphorus is high, look at creatinine. So this is how you establish the diagnosis. We have specific approach pathways which are dedicated to rickets in our application. You can use them to identify the cause of refractory rickets.
8-year-old male child, birth by fourth by birth order and birth of the non-consecutive marriage. He has presented with the fractures before 4 months due to the tribal trauma. That was the initial presentation, and child was not able to walk and stand due to severe bone pain. And this complaint has started since 2 to 3 years of duration. And child has taken tons of vitamin D and calcium supplements for the 2 years, and there was an inadequate response to this vitamin D and calcium supplements. And child has typical history that not gaining weight and height since 3 to 4 years. On the examination, we have in this X-rays, we are clearly seeing that a patient have a severe generalized osteopenia, pencil thin cortex-like a picture. The whole bone was affected. Typical rickets cell find like a cupping, praying and spraying was there. Healed fracture was there. It was on the lower limb, and there was the loser zone, which is a transverse line, which is a pseudo milk line, which is present in this bone. So it is suggestive of some severe underlying pathology. So if we conclude these 2 slides, then we are dealing with some severe pathology because patient had a fracture. So it is a pathological fracture with the refractory rickets because child has taken 2 years of vitamin D and calcium.
And if you have this sort of a case, such severe bone disease, such severe failure to thrive, even if he's coming without much vitamin D, you start off working up for refractory rickets. You should not wait for 2 months in this case because this is very, very classical.
So now we are dealing with the refractory rickets with the fractures, but there was no any history of polyuria, abdominal pain of the hematuria to ruling out distal RTA kind of picture due to the nephrocalcinosis. There was no any pictures of the chronic renal failure like decreased urine output or edema. There was no severe hypocalcemic features like tetany, convulsion. There was no any malabsorption syndrome like a picture like chronic diarrhea or steatorrhea. There was no another syndromic association was there like night blindness, photophobia, or bleeding gums like Lewy syndrome or another entity. There was no any history suggestive of severe chronic liver disease which is associated with it like a jaundice or hematemesis. So putting all things in our DD, we left with the 4 DD. So our possible diagnosis could be the renal tubular acidosis, malabsorption syndrome, chronic renal disease, hypophosphatemic rickets, or VDDR.
How many
Sir, present yes. As the refractory rickets, I put this diagnosis.
But if based upon your finding, that becomes very, very
yes.
Definitely CKD, yes. RTA, very much important. Malabsorption also, but it is very severe, sort of a bone disease which is there. For this level of bone disease, if it is because of VDDR, hypocalcemia would be
more severe. Yes.
That also will be less likely. So we're mainly dealing with a renal disorder. Tubular versus glomerular is the second question which will come up.
So as it was nicely discussed, VDDR, hypophosphatemic rickets, chronic renal disease, and malabsorption syndrome was less likely in this case because there was no history suggestive of. So our main diagnosis was the renal tubular acidosis. So now, otherwise in anthropometry, child was severe failure to thrive. Height and weight was less than -3 SD, and BMI was also severely low. On the general examination, BP was normal, respiratory rate was normal, which is showing that the child has no any acidotic breathing at that moment. And SMR was prepubertal, and pulse rate was normal, showing there was no any dehydration in this patient. Birth history, family history, and developmental history was normal. There was no any significant history on the maternal side. So in this slide, we are clearly seeing this child has a typical features of the rickets like rickettsial rosary, widening of wrist, but there was no alopecia, cataract, dental abnormality, or was no any chronic systemic illness like a pallor, icterus, or clubbing to ruling out malabsorption syndrome and VDDR2 or hypophosphatemic rickets. So in the summary, we have 8-year-old boy who presented with the non-contiguous marriage with the main complaint of not gaining of weight and height since 2 to 3 years, who presented with the bony deformity and taking treatment for the vitamin D deficiency for 2 years. So it is showing of refractory rickets and presented with the pathological fracture. So as we have discussed the 5DD of the refractory rickets, our possible diagnosis at that moment was renal tubular acidosis. Now question is that is it the renal, distal RTA or proximal RTA? So if we see the investigation, then there was a severe there was a normal calcium, normal to low level of calcium 8.4, phosphorus was low, and ALP level was severely high. So if ALP level is severely high, like 1,300, then it is pointing towards the distal RTA rather than the proximal RTA. Proximal RTA rather than the distal RTA. And there was a normal PTH level. Here, serum potassium level was 3.4, which is a normal to lower level. SGPT was normal. So again, if we combine these all parameters, then distal RTA was the less, it goes into the bottom because the potassium level was normal at the initial level.
So it was a very, very important investigation, which was basically overlooked, was the urinary glucose. So he had a positive urinary glucose, and that really gave us a diagnosis right at that point of time. That there is glucoseuria, this has to be a proximal RTA.
Yes.
So I think even other investigations can give you a clue. But yes, absolutely, as you have very rightly said, low level of phosphorus, normal level of potassium, and all those features, it is suggestive of a proximal RTA. And if you look at the blood gas now,
and blood gas was showing pH is 7.31, which is showing mild acidosis, not a severe. So in the distal RTA, acidosis would be the severe because proximal RTA self-resolving condition. So acidosis will be less. Here bicarbonate level is 16. And the base excess is also minus 9.1. Bicarbonate level of the 16 is also indicating towards the proximal RTA. So now to answering my previous question that it is the proximal RTA or the distal RTA. So here the twisting point has came. The urinary pH that we take into the definition, it was alkaline. So here it was the picture of the distal RTA, but the other parameter was suggestive of it is a proximal RTA. But as sir has nicely just told that urinary glucose is an important investigation. Here patient has a glycosuria, albumin was excreting from the urine, and there was a urinary calcium was high. Although urinary calcium level would be high in both type of the RTA, but there was no nephrocalcinosis. It was pointing towards the distal RTA. So if I putting my diagnosis, there all features was pointing towards the proximal RTA except the urinary pH, which was showing alkaline urine. Other than for the distal RTA, the age of the urinary severe osteopenia rickets, no no nephrocalcinosis or generalized proximal tubular dysfunction was against to distal RTA. So it is the proximal RTA. Now, according to some case report, urinary pH may be invariably normal in case of the proximal RTA. If we have no acidosis or mild acidosis, then urinary pH can be the alkaline. So this is
talk about ammonium chloride loading test to actually make them more acidic and then check the urine. So as we talk about diabetes inhibitor, we say that you need to have a concentrated blood, and then you will talk about the urinary osmolarity. Similarly, if you have not enough acidosis, urinary pH will be of limited value. That is an important thing to remember, and that's why proximal RTA is very, very difficult to diagnose. All the clinical features are there, but biochemical features may be variable in that scenario.
So here important message is if urinary pH is acidic, then it is more specific or sensitive towards the proximal RTA. If it is alkaline, then it could be the proximal as well as the distal RTA. For the management of this child, we have given the phosphorus supplement as phosphorus was severely low. We have started with the 40 milligram per kg per day. Bicarbonate was not severely low. So we have, because 16 bicarbonate was there, so we have started with the lower dose. But the interesting thing is that even though the bicarb is not very low,
as soon as you give bicarb, the bicarb goes up, you start losing the bicarb. So that is the problem. Just as we talked about hypophosphatemic rickets, you give phosphorus, you start losing more phosphorus. So it is going to be very, very difficult to build up the bicarb. While for distal RTA, once you correct the initial deficit, it's easy to correct. So this is so it's not very severe, but the treatment is
a very severe.
There, the treatment is easy, but initial severity is much more.
Yes. So,
what will you worry about once you start bicarbonate here?
Sir, as we start the bicarbonate, we have to worry about the hypokalemia because increase the sodium delivery in the distal tube will cause the hypokalemia. So, prophylactically, sometimes we have to start with the potassium. So, here bicarbonate, we started with the lower dose and along with the vitamin D and the calcium supplements. And as we have discussed, the potassium was started prophylactically 2 microgram kg per day. So in the follow-up, what we have to look in the follow-up for the proximal RTA, we have to look for the decreased ALP level, sodium and potassium balance because it can cause the hypokalemia. We have to look for the USG KUB to look for the nephrocalcinosis as we are giving the vitamin D vitamin D, and we have to look for the healing line. So as we have discussed, there was a case of the refractory rickets with the generalized proximal tubular dysfunction. And after 3 months, 3 to 6 months, we have advised for the genetic investigation because of the cost issue. So genetic reports has came which was clearly showing that was the proximal tubular dysfunction was associated with the syndromic form, which is showing that tyrosinemia type 1 in the FAH enzyme, and which is the pathogenic and likely pathogenic variant of classification. Here, I want to highlight about the tyrosinemia for the 2 slide. Tyrosinemia is associated with the metabolic defect in the metabolism of tyrosine, which contain the 5 different enzyme activity. If this enzyme block is there, then like a 21 hydroxylase deficiency, the proximal product can cause the damage to the liver, kidney, and the eye. So if it is and this block to conversion from the tyrosine to 4-hydroxyphenyl pyruvate, then it can cause the oculocutaneous type of symptoms. If it is blocked after that, then it create the symptoms like neonatal tyrosinemia. And at the final product, if it is blocked at the FAH gene, which is the fumaryl acetate hydroxylase, then it create the picture like type 1 tyrosinemia, which in our patient came positive. The block product of the succinylacetate cause the liver and renal damage in this condition, and it can cause the renal Fanconi syndrome and Porphyry's crisis like a picture. But in our patient, SGPT level was normal, and many case report, and according to literature, the tyrosinemia, the liver pathology includes in the first 2 years of the age, but in our patient it was not included. It was presented mainly with the proximal tubular dysfunction. So but we have the genetic report was positive. And how to make the diagnosis of the tyrosinemia? We can advise the tyrosine level, succinyl acetone level, enzyme level, or genetic diagnosis. More higher sensitive and specific diagnosis would be made by the urinary succinyl acetoacetate level or the genetic diagnosis. So if my answering to previous question, why this in this patient the liver was not that much affected, so some case report was suggestive of that in some case urinary liver synthetic function is more affected than the SGPT level. So we have not urinary liver synthetic reports at this moment. So in follow-up, it could be the affected, or it could be the cause of the
severe liver damage. Also, the SGPT level may not be very high. So SGPT is a marker of cell death. If already you have got a lot of damage which is there earlier, it may not be reflected. So we have to look from liver now from a more classical perspective. Maybe look at ultrasound carefully, look for portal hypertension features, look for prothrombin time, and other markers which will give us whether this is a chronic liver disease now. So that will be important.
But child have no hepatosmegaly. So And what are the management for the tyrosinemia? The ultimate management is the liver transplant. But after the medicine of the anti-BC nitisinone, the management has changed. It has a dramatic improvement in the patient with the tyrosinemia. So we can introduce, but it is a highly cost-effective medicine. And along with, we have to start with the low tyrosine diet, which is a low protein diet in this patient. So by that, the liver damage we can prevent in this perspective. Okay.
So I think that again was a very interesting case, highlighting the importance of genetic evaluation, because we have not just reached that this is proximal RTA, we have reached that what is the final cause. And that is very important because of other implications which were there in this case. So I think we will just to touch base about proximal RTA, what we discussed is that whenever we treat proximal RTA, we might need to give a higher dose of alkali, and this will cause greater distal delivery, and this distal delivery will activate the sodium absorption and potassium exchange. So when you treat, there is a risk of hypokalemia. So in distal RTA, there is hypokalemia from beginning, which improves with alkali therapy. In proximal RTA, you have normal potassium, which may worsen with alkali therapy. So you have to be cautious, as Manoj had already clearly said. You also have to give other parameters. And I is asking, the children with lower limb deformity have problem with their phosphorus, so that means phosphopenic rickets. You cannot generalize, Dr. Linda, like that. We expect that hypophosphatemic rickets will have a later onset and lower presentation. And this basically is that if you have predominant lower limb abnormalities, in this case, you have to worry about a possibility of phosphopenic rickets if there is no other problems. Dr. Sayan is asking any specific cause of dental abscesses in hypophosphatemic rickets. There are some local issues predominantly from the dental aspects, and people talk about this happening even without and even with treatment with burosumab, they tend to continue. So it's not just a direct phosphorus related cause. There is some other issue which is working on that. So patients with burosumab may have improvement in rickets, but their dental problems may persist, which means that it's beyond phosphorus. There is some other effect of phosphatonin which is playing a role, Dr. Sayan, there. Dr. Linda is asking, when does one test for 125 dihydroxylase? So calcitriol level, we should keep it only at a very late stage. If we look at our algorithm, we say you start off with phosphorus. If your phosphorus is low or normal, do a blood gas. If your blood gas is normal, do a calcium and PTH. If both are, if you have hypocalcemia with hyperparathyroidism, only in that case, you may do a calcitriol to identify difference between VDDR1 and 2. Dr. Tania is asking from Bangladesh, long-standing distal RTA present with generalized proximal tubular dysfunction. Yes, we have many cases, and that's because of secondary hyperparathyroidism. Your hyperparathyroidism will cause a Fanconi-like picture. So this, in fact, this case, or maybe a severe case like this, already had amino acid urea. So if you remember the chart I presented, 4 cases of distal RTA actually had amino acid urea. That is because of secondary hyperparathyroidism. So what I'm trying to say is that main aim is to look towards a diagnosis. Your diagnosis may not be established on the first day. Often you may have confusion, like we were treating him like VDDR2 initially, but he responded very well. So the main aim is for clinical improvement. So if you keep on thinking of diagnosis and don't give a proper treatment, there's no point. Similarly, proximal versus distal, the issue may be settled later on, but you have to give bicarbonate properly and then you assess from there. So yes, you can all go and have a look at our website, our courses which are available, and the mobile application. So